So I hope I do justice to Heather's memory in this lecture. It's a great honour to be here, and I hope you'll find what I say over the next half hour interesting and useful. And I think the very first thing I want to say to you is what you hear was not plan A. In fact, it wasn't plan B, C, D, E, F or G, actually, which is the first lesson I think you need to take away from this about your future careers. And actually, the main reason I am here now, where I am, is because of a couple, a bit like Heather, that I encountered quite early on in my GP career. And so the first 10 to 12 years of my career were spent trying to become a doctor and then trying to become a GP. And but unfortunately, within about a year of being a GP, and my father found this incredible, I even said this, after all those years of training, was that I said, I can't do this till I'm 65. This is just not enough for me. I said, I love it. I love the patients. I love what I do, but this is not going to take me to 65. And so within a few years of becoming a GP and working as a qualified GP, I had got a post at Newcastle University at the medical school doing some teaching and in medical education. And that was interesting, working with the medical students. And they just introduced a new community-based medical curriculum. I'm going back many decades here. Okay, I'm talking a long time before this was actually, the norm, if you like. And so they were looking for GPs who would get involved in helping to develop that curriculum. And so I started doing that 50% and working as a GP 50%. And that was really interesting. But around that time in my GP life, I was particularly interested in cancer and palliative care. In fact, I loved palliative care, and I became the GP lead for palliative care in my area, so supporting nurses and GPs to enable people who were terminally ill to die at home where possible, and got involved in training and stuff. But around that time, I met a couple who were both in their mid to late 70s, and they came into my consulting room, and the husband was worried about his wife's memory. And they had one son who lived hundreds of miles away, near Nottingham it was. And so I listened to the history and got them referred to the memory clinic, and yes, she had dementia. And soon after diagnosis, they came back to see me, and he said, I want to care for her. I want her to stay with me the whole journey. And I said, that's fine. I said, I don't see why that should be a problem, because I do that all the time for people with cancer and palliative care. In fact, that's what that's my job. I'm the expert in the practice, if you like. This is what I'm majoring in. And he said, great. He said, and my son's obviously keen, but he's 300 miles away. So we managed, and several years went by. And then it all got very difficult because she became double incontinent. He was over 80. He was really struggling with his own health problems. And one day he came into my consulting room and he said, we're going to move to Nottingham to me near my son. And I said, okay, that's fine. And I wrote a letter, to the GP in Nottingham explaining and put an advanced care plan in and what we'd worked out and how it was going to be managed and what they wanted. And sort of, we hoped and forgot all about them really. Until about 18 months, 2 years later, I got a letter in the post. And it was from Jim. And he was thanking me for the care that I'd given when they were in Newcastle. And he then went on to tell me how his wife had died. And she died in hospital, not where he'd wanted her to die, and not in a very good way. In fact, it was heartbreaking to read this letter because he gave me a blow-by-blow account of her final period. And it suddenly occurred to me that if you've got a diagnosis of dementia, which is a life-changing thing, and you've got a diagnosis of cancer, which is equivalent life-changing event, why should it be so very different? Because what I was doing on the cancer front, along with district nurses and Macmillan nurses in our local hospice, was just way, way beyond what these people diagnosed with dementia were getting. And so that was interesting because actually it was at a time when dementia research was really sort of in its infancy, especially care-based dementia research. The first World Alzheimer's report from Alzheimer's Disease International only came out in 2009. And I'm talking 15 years before that first World Alzheimer's report. And when that report came out, it was saying comments like national governments should declare dementia a health priority. So I'm talking 15 years before this, that I'm already seeing unacceptable inequalities in care that families with dementia are getting. So I suppose I'd sort of inadvertently found my passion. And the other thing I'd also found, but didn't realise it at the time, was I'd found my USP. And for many of my Newcastle colleagues and team, they always know I'm going to say, but what's the USP when you're writing a grant? You've got to get that USP. You've got to get that key thing that's going to make this stand out from the other 300. But I'd found my USP because when I started to get involved then and to explore dementia as a potential career interest area, I was often the only GP in the room. And this struck me as very odd because my experience in my clinical work was that people saw specialists to get a diagnosis and then they were discharged. And they might see them again if there were some challenging behaviour problems or medication challenges. But most of the time, these families were left with us in the community. And so we were doing all the care. And yet I would go to these conferences and there wasn't another primary care person in the room. So around this time, while I'm doing my lecturer's post in medical education and I'm sort of, experiencing what I'm seeing in my clinical life about the needs of people with dementia, a couple of opportunities came up at Newcastle University. And one was they were trying to get more of their young academics to do MDs or PhDs. So they had a fund, they had some local funding that people could apply for because there weren't opportunities like this. Getting PhD money tends to be with MRC, very science-based opportunities, and NIHR was not really around then. I'm talking a long time ago. So it's very hard to get funding for things like this. And so I thought, this is quite interesting. I'm getting a bit bored with medical education, having done it for a few years. So I might dip my toe in this research pool and see how that pans out, really. And I got one of these local scholarships, and my high degree was on a community geriatric teams that were just being set up in Newcastle at the time. But it also brought me in contact with this lady, one of my very dear friends and peers, Carol Brain, who just retired as Professor of Public Health at Cambridge. And Carol was a lecturer at the time. And most of the dementia research was lab-based. It was looking for a cure. It was it was very much about, it was very, very specialist. But Carol was really interested in studying in the natural environment, how people age. And she set up the very famous cognitive function and aging study. And I wasn't there when it first kicked off, but I was actually brought in because the innovative thing about the cognitive function and aging study was that they wanted to recruit from GP practices. So they wanted people over 65 recruited from GP practices. And Newcastle was one of the first 6 sites in the very first cognitive function and aging study. So I was aware this was going on. I was aware of the team that was doing this. But what was interesting was I then later on became the Newcastle PI, the lead for the CFAS2 study when it was funded 20 years later. And that was in 3 sites, Cambridge, Newcastle and Nottingham. And for those of you who don't know, the fabulous thing about this is not regarded as sexy research. You know, this is recruiting huge numbers of normal people from GP practice populations and painstakingly following them up over decades and often not getting the money to do it. So part of the reason for the 20-year gap between CFAS1 and CFAS2 is we could just not get any more money to do any more of this until we got that second 20-year follow-up. And the great thing about that is we didn't know this at the time, but this would be really groundbreaking stuff. And I know the new drugs are very, very exciting, and that's where all the money's going. But this, to me, is one of the biggest breakthroughs in dementia research in the last 10 to 15 years. Because what CFAS and other international cohort studies did was they showed that whereas we should be having more people with dementia because we were aging populations, in fact, the numbers were less. The actual numbers were less than predicted. In England, it was 20% less. So why did we have, a fifth less people with dementia when we were a rapidly aging population? And of course, that led us all, and I'm only talking a decade ago, that led us all on to this concept that dementia is complex and there are risk factors and there are things we can do throughout our life course to reduce our chances of getting all types of dementia. The concept of risk reduction and preventing dementia is actually a pretty novel concept. In fact, prior to the turn of the century, there was very little research on the concept of preventing. And now we know, the Lancet Commission through Jill Livingston has led, we know now 14 modifiable risk factors. And all of that has come from the big cohort studies, which enabled us to look at the people who did get dementia and those who didn't, and what the different factors were in those people's aging trajectories. And now, of course, dementia is classed by the WHO as a public health priority. And interestingly, the Alzheimer's Society were one of the first to acknowledge the concept of prevention as a key aspect of dementia research. With their roadmap in 2017 meant that their strapline of care, cure and cause suddenly had prevention in. And I think that was very, very risky, very brave of them, because way before any of this came out, they could see that this was not just about finding a cure and finding drugs. But of course, this is really, although I was involved in CFAS, which took a lot of work, this was where my passion was. It was about people getting a timely diagnosis and an accurate diagnosis and then getting care and also supporting their families. So this is where my personal research program started to develop. And I managed to get a few small grants and then some medium grants. But my big break was actually when I won, as Rich said, one of the first round of the NIHR research professorships. And I suppose this was my personal fellowship. So it came a lot later than a doctoral fellowship or a postdoctoral fellowship, but it was pretty life-changing for me because, one, this gave me 5 years of protected funding to focus most of my time on research. It enabled me to reduce my clinical work to just 2 sessions a week. It removed me from any teaching and examining and all those kind of responsibilities that you have to do as an academic, which takes a lot of time. And it also allowed me to focus on, if you like, the areas I wanted to focus on. And again here, 2 areas that I was particularly interested in because I thought they were very important. My specialist colleagues at the time didn't particularly think they were, was the area of end-of-life care, because what I saw is people dying with dementia, and they were even more disadvantaged than those that were diagnosed with dementia, because there was often nothing, there was no support for families. At the time, cancer hospice care was not really that involved, and these people were just not really getting the sort of care they deserved. And also technologies. And one of my very first small grants was in technology and was actually involving, in fact, I think it's still the first paper to report the involvement of people with dementia in co-designing technologies. Because up until that point, it had just been done with family carers by proxy. And I wanted to show that you could involve people with dementia in the early stages of designing technology. So I started my professorship and it was great and I was exploring these areas and I used it to win an NIHR program grant focused on improving end-of-life care for people with dementia. But I was a bit mortified to read an Alzheimer Society report a decade ago now, this was 2014, 2015, which according to their statistics showed that still around 40% of people with dementia didn't feel they were getting appropriate post-diagnostic support. And I thought, this is decades after I started trying to improve things. What's going on here? You know, we really need to make a difference. And around that time, the UKRI Dementia Research Institute had been set up, which was great news. That was, you know, hundreds of millions going into finding a cure and finding new drugs. But the Alzheimer Society, not quite the same amount, but recognised that as well as trying to focus on finding a cure and finding cause, you had to look at care. And they funded 3 what they called centres of excellence, big programme grants focused on care. And I was lucky to receive one of those centres of excellence. And the one that I led in Newcastle together with my UCL and LSE colleagues was looking at improving post-diagnostic care. Because one of the things I'd found from my end-of-life programme grant was that you can't just put an intervention in at the end of life for people with dementia. You have to get it right at the start. And you have to follow that through with consistent good care to enable people to die well and not just live well with dementia. And this has been really quite an incredible grant. It's produced a lot of papers. It also showed that, unfortunately, when we looked at the current service provision for post-diagnostic care for people with dementia in England, that the geographical inequalities were much greater and much wider than even we thought they were. That was the first phase of it, looking at what currently was happening. And that informed some key Alzheimer Society documents, policy documents, such as From Diagnosis to End of Life and Left to Cope Alone. But we also then, the second half of it, set out to develop, if you like, a best practice intervention for delivering primary and community care-based post-diagnostic support for people with dementia. And the PRIDEM programme, then we did a pilot study. We didn't have enough money to go to a trial, but we did a pilot study which had some very encouraging results and was actually selected as one of just a small number of case studies for the 2022 World Alzheimer's Report on post-diagnostic care. But the other thing I think it's done is I hope it's helped shift Alzheimer's Society policy, because I was delighted to see that in the last year or so, they've started to raise the concept of inequalities as a key policy focus for them. And their annual conference this year, as many of you may know, is on inequalities. So now really we've got a society which is funding research, not just on cause, cure and care, and prevention, but also hopefully inequalities and reducing inequalities. So the other thing I've really enjoyed doing, but a word of warning here, is it's not just about getting grants and writing papers. You know, it's about impact in other ways, as you now know. And I've tried to do this as I go along. These are some massive open online courses that we developed in Newcastle. There's 2, one on getting a diagnosis of dementia and living with dementia, getting early support, and the other is on advanced dementia and providing end-of-life care for dementia. And they won the Best Education Award at the National Dementia Care Awards in 2019. And their global reach has just been incredible. We're quite blown away with it. A lesson to learn, though, is we hosted these on the National Future Learn platform, which is the MOOC platform nationally, but the university then removed their contract with them. So they've been homeless for a few years, but we've now managed to set them up at Newcastle University with some additional funding. So they've just gone live again. So they're now available through Newcastle University and available for people to do if you're interested. This is an interesting project we did at an international level with UCL colleagues from England. It was about developing an online toolkit for future care planning from the Cognizance project. And again, a very useful tool. But if you're doing impactful things like these, you have to find a long-term home for these things. And the Alzheimer's Society can be potentially helpful in perhaps helping you do that. So that's all been very good. But another area I want to just, before I talk about is, if you like, my fourth career, which again came about quite serendipitously because NIHR announced global health funding call in 2018. And I'd never particularly done any global health research. But two of my young team said, oh, should we have a go at this? What do you think? And we had 7 weeks to get the bid in. And that was with partners from lower middle income countries. And it was over December, January period. So the timing wasn't great. But Newcastle University has a medical school in Malaysia, so I had research colleagues in Malaysia. And one of my geriatric colleagues at Newcastle had decades-long relations with Tanzania, and we'd been having an exchange programme with Tanzania. So we managed to win one of these very first NIHR Global Health Programme grants. And we won 2 million, and it was with our partners in Malaysia, Angola and Tanzania. And this has been really, I could just keep on doing this for the rest of my life, because working with these colleagues in lower middle income countries is just eye-opening. These people have nothing a lot of the time. And although the wonderful drugs are, as we know, exciting and promising, they'll never get these drugs, probably in my lifetime. And a lot of the time, people can't even get a diagnosis. So, it really brings you back to basics when you go and work in these countries. And this is just one of the outputs of this programme. And, we found that they were using the mini mental state examination translated into local languages. But, asking someone who the Prime Minister or the Queen of England is has no relevance in rural Tanzania or in a coastal village in Kerala. So, colleagues came up with this idea of, if you like, a more global health cognitive assessment tool. And it combines cognitive assessment with looking at activities of daily living. Because many of these older people have not had education beyond the age of 10 or 11. Their jobs have been farming or fishing or being community elders. And so what you see is not changes in cognition, but you see changes in function first. And we adapted some standard UK, Western ADL tools into locally relevant activities of daily living tools, combined them with a cognitive screen, and actually put it on an app, which people could then go out into the communities to use. And another key output of this global health grant was, again, one of the things, and it took me 3 years. We're 3 or 4 years into the programme at this point in time, but suddenly realised that most of these patients couldn't get access to the basic existing dementia drugs like donepezil. They just didn't get them. They weren't available. And then it was because the WHO didn't class the existing dementia medications as essential medications. So if you're not on the WHO, if a drug's not on the WHO essential medicines list, then your ability to get it globally around the world is severely inhibited. I mean, like at an NHS level, I don't mean if you've got money, and at a private level. So what we did is we developed an application to the WHO Essential Medicines Call, which comes every 2 years, to see if we could put forward a case, a clinical and cost-effectiveness case for getting donepezil included on the WHO World Essential Medicines list. We felt it was a public health issue. We felt it covered all the tick boxes, and this took a lot of work, as you can imagine, and it went in, but actually we weren't successful. And so dementia, there is still no dementia medication on the WHO essential medicines list, despite dementia being classed by WHO as a global public health issue. So, moving swiftly on. So what have I been up to in the last few years? Well, this was an interesting spin-off project, which I got pulled into, back to my area of technology and looking at the role of technology in caring for older people. And I got dumped with writing and leading a bid for the 40 million National Innovation Centre for Ageing in my role as director of the Ageing Institute. And that was interesting because that was really, and we were told we don't want lab-based stuff, we don't want technology, we want something different, we want something that's going to make a difference to people in the community. And so that's what this now does. I wasn't allowed to be the lead for this, although I wrote the bid and saw it to development because they wanted a business person to be the director, but I still am involved at an academic level, and this is now thriving at Newcastle and quite an exciting place to work. I'm now involved in one of the two NIHR policy research units on dementia and neurodegeneration. And it's interesting that of my colleagues from the Alzheimer Society PRIDEM programme, the Centre of Excellence programme, my UCL team, our colleagues are on the other PIU, and Newcastle and LSE team are on the Exeter-led PIU. So we're both involved at this policy level, but in separate PIUs. And this is now working directly with DHSC and NHS England to do dementia and neurodegenerative research questions set by DHSC. And there's another interesting concept which I think will be of relevance to you, this concept of capacity building networks. So there were 4 dementia networks funded by SRC announced last year, and these are not to fund research per se, but they are to fund innovation and capacity building and are available for small research grants, for research internships. Actually, the people who run these, we can do anything but spend them on research. We have to try and build capacity. And I'm co-lead with my colleague Clarissa Giebel in Liverpool of the Inequalities Equiderm Network. So it's worth having a look on our website. We've been going about a year now because there might be some opportunities for you there with the funding calls that we've put out. And building on those ESRC networks, they're now Dementia Plus networks on technology funded by the EPSRC, and there's 4 of these parallel networks being announced, and I'm actually on 2 of these, one led by Imperial, and we have a north-based one led by Northumbria and Newcastle universities, specifically looking at developing and getting technologies into practice for people with dementia. So, what do I want to end with? Well, I think, as Rich says, the importance about dementia research is getting people like you to stay in it. And I hope I've given you some tips how to do that, and I'll summarise that at the end. We certainly need more people involved in it, although it's definitely a more exciting area than I think it was when I entered into it. And a chance conversation I had over coffee with Fiona Carragher, Alzheimer Society, and Robin Posisano at NIHR actually led to the Alzheimer Society NIHR DEMCOM scheme, because both wanted to do postdoctoral fellowships in research and both were thinking about doing it. So I said, why don't you two guys get together and do it together, then you can fund even more, which was really exciting to see. And the Alzheimer Society doctoral training networks, of which I'm part of the Newcastle-led Lewy Body one, which again is incredible to see those being funded. But I just want to leave you with some thoughts, really. As I say, it's great and it's really exciting to see all of this money now going into dementia research and many more people involved in it. But I just want you to think about where that money's going and what that focus should be. Because when you read a lot of the initiatives, it's things like develop new diagnostic tests and bringing together industry to speed up drugs into the population. And I hope I've shown that dementia is much more complex than I think just perhaps finding a drug, which we do need, and I'm not saying it's not important, but I'm just wanting you to think about how we should be using the money. And yes, NICE currently finds the new drugs not cost effective, But even if they had voted to get them into practice, they're only available for people with Alzheimer's disease, no other type of dementia. Of the current people diagnosed with Alzheimer's disease, only around 5% of that population would be eligible for these drugs. That leaves the vast majority of people living with dementia in this country who won't even be eligible for these new drugs. So what happens to them and what do they get? And this is a project that our Policy Research Unit has just carried out, commissioned by DHSC, about looking at, if you like, what's going on in Parkinson's disease research and where the money's going and what the outputs are. And I want you to look at the table over here. And this is Parkinson's, but I think if we look at dementia, it will be very similar. So we have around 9% on prevention, 12% on diagnosis, 75% on treatments, and that'll be drug treatments, 3.9% on care. It's quite eye-opening, really, I think, looking at those figures to see where that research has been done and where the money is going. And just to emphasise that, this is a current project that we're just winding up, funded by NIHR and the Alzheimer Society, looking at dementia care in hard-to-reach communities, so rural, remote locations, ethnic minority groups, low socioeconomic groups. And I just want you to look at some of these quotes that my interviewers in the Northeast who've been looking at Newcastle and in rural Northumberland. And the majority of the quotes from participants were like this. And I wish it could be different, because it feels like the years I've spent doing this have not really made any difference. But I suppose I say it because it's still important. And it's important to realise that dementia is not just a diagnosis or a drug. It's much, much more than that. So, what lessons do I hope I can give to you? Find your passion, okay? Because you'll never get through a PhD or a postdoctoral piece of work without loving what you're doing, without living and breathing what that research is. And find a USP, okay? What about what you're doing makes it different? Because you've always got to look for the USP to get that next grant. I hope I've shown that you don't have to go down a motorway to be successful. I got my higher degree, my research degree, when I was 37, at 37 weeks pregnant. And when my examiners in the Viva said, "How long do you want to do your changes? 3 months, 6 months?" I said, "Make it a week." Just in case. And I think the other thing is, I've been speaking to some people already, some of you. All of what you've done to get to this point will be relevant. My GP skills, my ability to speak in a language that is understandable by not just the research community, but by families living with dementia, has been a huge asset to me. And I didn't learn those skills in my research career. So everything you do is relevant, transferable skills. And if if somebody says to you, when I tried to go from medical education to research, I went to see my professor and he sort of looked at me, I was barely in the room 5 minutes, and said, "But you're not going to make it, you've not had any training." So, okay, just think about transferable skills. Start small, okay? It's fine to get small grants. Even if it's 5,000, okay? Just get those small grants. It's all relevant. And think about sometimes going outside your box, doing something completely different. Mentors, I can't stress the importance of having mentors, and have more than one mentor. People bring different experiences. Everybody you talk to will have a different lesson to learn from you. And think about the bigger picture, because the people who really matter are the families living with dementia. And I joke when I said it never was plan A or plan B, but we've got our 40-year medical school reunion later this year. And so they've been recirculating our, medical school yearbook. and our entries, which I'd completely forgot about. I don't even know where my yearbook is. But it's very interesting because actually suddenly I was faced with this, which wasn't written by me, it was written by friends. But you do just wonder, don't you, if perhaps somewhere way back there was something that said I might actually become a dementia researcher. Thank you very much.